he doesn't eat right, he doesn't exercise enough. It's his fault he's like this or she's like this. And I think we need to break that stigma first.
Ozempic, Wegovy, Rybelsus, which is the same thing, which is Semaglutide. Then comes Monjaro, which just launched in India. And the future molecules, like the myths around it, criticism around it, and the influencer jargon around it.
GLP-1s have been proven to be cardioprotective. They've been also proven to be protective against chronic kidney disease. So we've got so many benefits from the medication. I'm not saying everyone who's obese needs to be on it. No. I think it's really, really important, and this is for all the people who have this stigma against the medication. Like, if you couldn't do it naturally.
Hi guys, welcome back to Infinite Health. It's been a long time, but I think we're finally doing an episode with Dr. Roohi Khanna. She is an obesity medicine specialist. In this episode, we've spoken about something which is very personal to me, which is obesity and obesity medicine. Now, if there's anything that you need to know about Ozempic, Mounjaro, Rybelsus, and all the new future drugs that are coming to help you in your fight against obesity, this is the episode you need to watch. Because we've spoken about all the insights into how these work, what is the good, the bad, the ugly. So watch on. Dr. Roohi, welcome to Infinite Health. We're just beginning our season 2 and I'm so happy you could make it.
Thank you so much for having me. I'm excited.
I mean, just to begin with, like, what is obesity medicine?
Right. So obesity medicine has been around in the West for a while. This is, I would say, a little bit newer field. But what we are doing as obesity medicine clinicians is we are looking at those patients who've been struggling with their weight maybe their whole life. And a lot of it is, hormones, lifestyle, mental health, and also nutrition. It's all a combination. So we started to deal with all those really difficult cases. So when you went to your general doctor, look, they didn't have time to deal with everything, right? You go to the endocrinologist, they're managing your hormones. But no one ever sat down with the patient and looked at everything and tried to understand everything. Because now obesity is considered a chronic disease, a relapsing remitting chronic disease. What does that mean? It's like diabetes being a chronic disease, right? So same way obesity is. So now we have these specialists who are dealing with it. And I wouldn't say we are alone in it. It is a team effort. I still say this. You have the doctor, you have the health coach, you have the specialists, you have the nutritionist, the mental health. It is a team-based approach. So that's where that field, I think, came about. And I think it's spreading now. I mean, we're all fellowship trained in the US, board certified. And now we are starting to see the need everywhere.
No, I think because obesity has, even personally, like I was very obese as a child. I was 155 kilos and there was a lot of topsy-turvy. Like you said, like it's always come back. It's like you lose it, you gain it, you lose it, you gain it. And the world is changing so much now because in this podcast, I really want to talk about, Ozempic, Wegovy, Zepbound, and all the other molecules that are about to come. But before that, I really want to understand what obesity is for the audience because I think, and in fact, there are two things I want to talk about obesity. Is that obese that you can see and obese that you can't see.
Right.
And since we've had this discussion before, let's start with the basics. What is the obese that you see?
So obesity, if we're going into the definition, it is defined by body mass index currently, right? Well, however, we've found that depending on where the population is, the BMI number is different. So for someone who is in India, the BMI is 23. And why do we see that is because, look, they probably don't have as much muscle mass, but they have a lot of abdominal obesity. So we're starting to use different parameters to classify them. So like you said, the skinny fat. Someone who has, a BMI of 23, but they have a large abdominal circumference or a lot of visceral fat is deemed obese. Same way in the West, we use BMI above 27 to classify someone as overweight, but they also have medical comorbidities like high blood pressure, high cholesterol, PCOS. All these things also contribute to obesity. So I think that's the basic definition that we see with obesity, and the classifications go from there.
Right.
I brought up visceral fat, and I think that is key when we're looking at someone.
Just for the audience, what is the difference between visceral fat and subcutaneous fat?
So subcutaneous fat is the fat that you and I can see. We can touch it, we can pinch it. we feel
The
it.
skin fat.
Right. It's easily, it's seen by the naked eye. The visceral fat is the fat that's surrounding your organs. So it's around your intestines, your liver, around your heart. And we cannot see it unless we do a scan on you, like we do a CT or an MRI, then we'll be able to see that. But otherwise, we won't be able to see it. We do DEXA scans as well to understand, the composition, and certain composition analysis, body composition analysis will pick it up as well. The visceral fat is, the good news is, highly metabolically active, meaning we can reduce it with lifestyle changes, diet, medication intervention, but it's also the one that's giving rise to the diseases like diabetes, heart disease, stroke, cancers. There's like 16 different cancers obesity
So,
can cause.
would you say like visceral fat is more dangerous and subcutaneous fat
Yes.
is more cosmetic in nature?
100%. Visceral fat is more dangerous than subcutaneous fat.
The only reason I brought this up is because I actually put out a thread and tweet just a day before, where I said that India has the highest number of lean diabetics and lean heart attacks that people know of, like, the curse of Indian obesity.
Right.
Thin outside, fat inside.
Right.
But just now that I want to really dig into what I really wanted to have this podcast about, which is basically Ozempic, Wegovy, Rybelsus, which is the same thing, which is Semaglutide. Then comes Monjaro, which just launched in India, and the future molecules, like the myths around it, the criticism around it, and the influencer jargon around it. Because I personally, I just want to state out to my audience right now, that even before we start digging into this, is that I did make a reel on, I do feel that these are great for the world right now. India being the obesity capital of the world, I do feel that it is a godsend, and that this will help a lot of people in their journeys who cannot lose weight. So there is a certain bias that I'm coming with. So I just wanted my audience to know that. But let's just dig in. Like, now that we've defined obesity, I want to understand, first, let's just understand Ozempic, which is basically semaglutide as a molecule. And what is the mechanism of action there? Like, what does it exactly do?
So GLP-1 receptor agonists are basically medications that basically bind to the GLP-1 receptor sites. They're peptides. And what they're doing is they're helping to increase that level of hormone in you and me. You make it, I make it. As this hormone increases slowly and steadily, we start to feel full. We start to feel satisfied. Appetite goes down. Cravings go down. Addictions go down. Also, we start to see better glycemic control, better sugar management because of increased insulin production. And as a result, we go into a caloric restriction and we start to lose the weight. And the hope is that we lose the fat and not the muscle mass, because a lot of patients and a lot of people have concerns, and they're very valid concerns. I wouldn't say that. But that's how the GLP-1 agonists work.
Right.
Now we have semaglutide, which is just a GLP-1 receptor peptide agonist. And now terzepatide is a GLP-1 receptor agonist as well as a GIP receptor agonist.
What's like a GIP agonist? Does it work similarly to a GLP-1?
So this is also an incretin hormone, and it works a little bit better with the insulin production. So it works on the pancreatic cells, and it helps more insulin production. Now, because terzepatide has both of them, we do see a lot more, or I would say 20% more weight loss with terzepatide and fewer side effects. Because with semaglutide, we see a lot of GI side effects.
Right.
Terzepatide actually shows fewer side effects.
So you're saying that something like a Mounjaro
Yeah.
would have lesser side effects
Yeah.
than something like a Rybelsus or an Ozempic?
Yes. Yeah. Because look, Rybelsus, first off, is an oral semaglutide.
Right.
So when we take oral medication, the bioavailability also goes down a bit, right, because of the gut. And a lot of times, patients, if they're taking it incorrectly or maybe not taking it, I would say, adequately, they might notice more side effects with it. But with the injectables, we do see better results and fewer side effects, but specifically with terzepatide, we see fewer side effects. Maybe because it's a newer GLP-1 as well. Right. And so it's, some kinks are worked out, but we do see that patients tolerate it better.
I think, just addressing, reducing appetite. Something that I want to understand is that are you reducing the appetite to less than normal? Now, when I say normal, I just like to clarify that I'm not talking about the patient's normal. I'm talking about what normally a human being should have had. Because a lot of people feel that it'll reduce your appetite to an extent where you won't be able to eat at all. I mean, is that true?
So if you are taking this medication and you find your appetite is going down and you're not eating appropriately, meaning you're not getting the proper micro or macronutrients, you will have a lot of effects from the medication, such as excessive hair fall, muscle mass loss, fatigue, right? The point of the medication is to give you enough room to eat, essentially, eat so much so that you are providing your body the full nutrition. But if you don't appropriately eat on the medication, you're going to lose out a lot. Right. So to answer your question, hey, is it reducing my appetite to the point where I'm not going to be able to eat at all? No, you still have an appetite. And that's also very key to understand. A lot of patients will come back and I'm taking the GLP-1, I'm still hungry. Yeah, that's a good sign. We want you to have a good appetite. But what it's helping you do is helping you to portion it. So you're sitting down for a meal and you're like, I could eat this all before, and now I'm finding myself eating a third of it less. You're also starting to feel the effects much sooner. GLP-1, when we make it, right? You and I both make it. It has a short half-life. You may have read about this.
Yeah.
The injectable has a longer half-life, right? It's used once a week. It's a once-a-week injectable. So when we are eating, our body's releasing GLP-1. The thing is, it's got a short half-life. So if you sat down and just, ate your meal and you waited 20 minutes, you'll realize, I'm done. For most people. Some people don't have that, I wouldn't say luxury, but that feeling of satiety. Right. Which is why it comes in handy for those patients.
Because I read a big paper on leptin resistance also.
Yeah.
It's basically when you start dieting naturally without, these GLP-1s.
Yeah.
People, even though they're actually full, their leptin doesn't signal their brain that they are full.
Right.
And it just doesn't stop. You
Right.
keep feeling hungry because you feel that, you're hungry, but you're not really hungry, that your stomach is full. And I think what a lot of people are not talking about is also how it impacts your leptin resistance.
Right.
In this criteria, because I think just coming back to the appetite portion, from appetite we move on to the other side effects, which are basically, bloating, diarrhea. Does this go away with time?
So with the GLP-1s, most commonly we'll see constipation. We do see diarrhea sometimes. Not everyone has it. That is the function of the medication, though. So GLP-1 slows down the digestion process in your gut, which is what stimulates the constipation. So it makes you feel fuller.
So just coming back to the side effects that we were talking about, do these go away with time?
So the side effects, such as the nausea, vomiting, constipation, acid reflux, if you're eating appropriately on the medication and timely and under guidance, you can prevent it, or yes, you can probably notice as we are taking the medication, they start to decrease for most people.
Right. So, we spoke about the side effects of this drug. Now, I really want to move on with the 4 or 5 main complaints that I get, or, the kind of rants that we get. And I really want to address this through you, and which is, the first is thyroid cancer, that FDA has put a label on Ozempic that it might cause thyroid cancer. What is the validity of that?
So this study was done on rats, on rodents, and they found that they had this genetic predisposition to develop medullary thyroid cancer. So the study has not yet been replicated in humans. And so we don't actually have data saying, yes, you will develop medullary thyroid cancer in humans. Nothing yet. And actually, the most latest study, I believe, where they tracked patients for 8 years, saw, I think, a 0.1% chance of developing medullary thyroid cancer. So it's a contraindication if you have any genetic predisposition to develop medullary, like it's in your family. Then I, as an expert, will say, or as a physician would say, listen, let's avoid a GLP-1 in you, because we'd rather be safe than put you at risk for anything. So I would say proper family history, past medical history, understanding the individual, and then prescribing the medication to them would be key.
Because, like I just like to add, because I did a lot of research on this, like for the MTC. I mean, you're absolutely right that it was done in rodents. But there's also a lot of clinical studies which have shown that it actually protects your thyroid if you take it for 18 months. That initially the risk increases. It's almost like a peak curve. That initially the risk increases, but then it goes down. In fact, it is protective against the thyroid, because it sort of makes you lean and makes your thyroid work less for the same amount of body.
So it helps those patients who are struggling with hypothyroidism, let's say, or subclinical hypothyroidism.
The only fact that irritates me is that, like, these influencers get like a ticket to sort of talk about how Ozempic causes cancer, and like it really frustrates me that I can't say or do anything about it. But like thyroid cancer was one of them. The second complaint that I get a lot is about the vision problems. Like so many people, right? Does it have vision problems? Was it like a rare case, or is it true?
So NAION, right? That's where we have an eye stroke, basically. We have GLP-1 receptors everywhere. This was so rare that I think it was 8 to 10 patients out of 100,000 that they saw it. And the study was done at Mass General, where I think you get the rarest of rarest cases, like ophthalmic cases. So, I mean, not to say that, hey, it's not a risk factor. If a patient experiences it, we immediately take them off. But it's so rare, Anant, that I would say you have more pros of being on the medication, like if you're struggling with obesity, because look, you're at risk for developing heart disease, which is a heart attack, stroke, cancer. So it is a good discussion to have with your doctor. I think every patient should, if they have concerns, should sit down with their doctor, have a full discussion, understand the pros and cons. I think it's with any medication. Anyone who takes paracetamol every day can have liver issues, right?
Absolutely.
So, I mean, it is a conversation where we need to decide, okay, pros versus cons. I have more benefit to being on this medication. GLP-1s have been proven to be cardioprotective. They've been also proven to be protective against chronic kidney disease. So we've got so many benefits from the medication. I'm not saying everyone who's obese needs to be on it. No. I think it's really, really important, and this is for all the people who have this stigma against the medication. Look, if you couldn't do it naturally, up until now, we have a tool that can help you. It is not a shortcut. And I tell that to every patient who walks in. This is not a shortcut. You still need to work on your lifestyle. You still need to work on your diet. You still need to work on your mental health and all your other metabolic issues. This is a tool that will help you achieve your goals. And I also want to clarify, the goal isn't like, I want to get really skinny. No, we want to improve your metabolic health. We want to reduce your chances of developing diabetes. We want to reduce your chances of developing heart attack or stroke.
I mean, I personally also see this as a way of optimizing longevity in life. Like, I mean, I might be on a controversial gray area here, but this is just my personal opinion. I feel like the one thing that a lot of people don't understand is, like you said, like measuring the pros and cons. And it's not like everyone needs to take it.
Right.
It's just that if people have had chronic obesity, which comes back again and again and again, and then they've tried everything, they've tried the food, healthy habits, they've tried the exercise, and they've still got it, I think those people would be better off with it. And even as the vision problem is concerned, like, I think it's like the rarest of rarest case.
Correct.
Like you said, and again, I'm going to make another controversial statement, and I personally don't care, but I'd make it anyway. It's like, if you speak to liver doctors around the country, they'd say ashwagandha is also very dangerous for the liver for certain people. Like, it's a thought experiment that I do with a lot of people I meet. Is I would say that if I flip a coin, what are the odds that you would win? And, everyone would say 50%. Now, I would say if I flip it 10 times, will it be 5 and 5? Like, if you put it to a larger population, every single drug, supplement, even food for that matter, you could die of a food allergy that you've not had in your life.
100%.
Like, everything has certain odds. And like I find it very frustrating that people don't understand that and they just pinpoint one bad thing and they don't look at a larger perspective. So the fourth thing that I really wanted to understand from your perspective is about pancreatitis, because again, it's like spoken about a lot in terms of Ozempic.
So initially, patients were, again, it's rare. It's not one very common side effect. But what we were seeing was that if the lifestyle changes, like say someone who is an alcoholic is drinking while being on a GLP-1, obviously there are increasing chances of pancreatitis from just drinking the alcohol. And we found that the GLP-1 actually had no correlation to that. So I feel like that myth has been debunked. It's
Right.
not putting you at risk for developing or increasing your chances of pancreatitis. If you already had that risk factor of idiopathic pancreatitis, then that chance is there.
It would have happened anyway.
Correct.
So, just like I wanted to summarize this section where we were talking about semaglutide, which
Yeah.
is basically just a GLP-1.
Right.
And before I move on to Monjaro, I want to sort of summarize this section in terms of the pros,
Yeah.
the cautions,
Yeah.
and the possible cons. Like
Right.
as a pro, I mean, it's great for improving your metabolic health.
Right.
It's great for reducing obesity.
Right.
It's great for, I would say, breaking addiction centers and habits.
Right.
Because once the GLP works on your brainstem, it also works on your smoking and your drinking.
Correct.
And it's cardioprotective.
Yes.
So, I mean, these are the main things that it helps you with.
Right. Right.
Like as a side effect, I think it goes away with time for most people.
For most people, the side effects improve with time.
And with cons, who are the ones who absolutely shouldn't be on semaglutide?
So the absolute contraindications would be someone, like we said, has a genetic predisposition towards medullary thyroid cancer, multiple endocrine neoplasia as well. The other case is where they struggle. I wouldn't say this is a contraindication. I would say this is more of a caution. If you struggle with chronic constipation, let your doctor know that
Like
this
an
is
IBS, you mean?
like an IBS-C picture. Though we've seen some people improve with it as
Right.
well. But I would say be aware that, let your doctor know this is something I struggle with, because then we can be monitoring you more carefully. It's not a absolute contraindication. It's more of a caution.
Right.
So in that case, acid reflux and dyspepsia, again, it's more of, hey, if you're eating appropriately on it, the GLP-1 should not aggravate it. But there have been cases where, because of the decreased appetite, you're not eating as much, you're having large gaps between your meals, so certain patients will experience it. But we can always work around that. These are the absolute contraindications, the cancers is what I've kind of discussed. But everyone else, have a discussion with your doctor. Make a list of the pros and cons if you should be on it or not. And I think that would be very helpful. The other group of patients that I forgot are pregnant females.
Right.
We should not put pregnant females on GLP-1s. Why? Because we have no research or studies yet.
Fair enough.
So,
And it would be difficult to do a study on that also.
yeah. In fact, we counsel patients, because we do work with fertility patients as well, that you have to be off the GLP-1 for 2 months before you even try to conceive.
Right.
You should, ideally. But we have seen fertility rates go up on GLP-1s. You may have heard Ozempic babies and
Yes,
stuff.
I was just about to bring
Yeah.
that up. Like Ozempic babies has become like such a popular. Like, what does that mean, Ozempic babies?
So while patients were on Ozempic, they had a good amount of weight loss, probably a lot of hormonal imbalance restoration, right? So they're PCOS patients who were struggling with fertility. So they, lost the weight, which is the treatment for PCOS, right? And as a result, the estrogen, testosterone, progesterone all came in balance and their fertility went up.
Right.
Maybe they were not using a backup form of contraception and boom.
But like, I'm just thinking out loud here, and like there's a doctor called Dr. Tina Moore. Like she is an American health influencer and also a naturopathic doctor, and she speaks a lot about how Ozempic in microdoses, not probably in higher doses, really solved her autoimmune disorders, and that it's like a great like for psoriasis, for arthritis. For all the minor autoimmune conditions, that it's a great thing if it's done in microdoses. But then Eli Lilly or Novo Nordisk, like the bigger pharma companies, they don't subscribe to microdoses as such. And by microdoses, I'm saying like lesser than the least
Correct.
dose of.
Correct.
I mean, do you see any potential benefit of that?
So going back to what you were saying about how it helped restore or reduce inflammation, I think that was one key thing you were getting at. We have some studies that are showing that GLP-1s are helping to reduce inflammation in the body. And that makes sense, right? Because high blood sugars, obesity increases your chances of developing inflammation. Now, thought of microdosing, it is not yet FDA approved because it has not, again, been studied. But
Only compounding pharmacies are doing
compounding
it.
pharmacies are doing it, correct. And so what is compounding medications? They're not branded. They're not Wegovy, Monjaro. And they come in these vials and you can adjust your dose for the medication. We've actually seen, not practicing it, but we've seen some clinical trials on microdosing and hormone replacement therapy be really beneficial for women who are going through menopause. And these studies that you're talking about, or these patients that you're talking about, helping them with inflammation, I've seen it in my practice from being on just Mounjaro or Semaglutide, such as Ozempic or Wegovy. A lot of IBS issues, a lot of autoimmune issues do calm down. We have seen that. Now, this is more of an opinion than a clinical study, but there are clinical studies going on this.
No, we have seen a lot of patients around us. Like, we've studied so many patient data, like who've been on Ozempic and Mounjaro for the longest time, and like we have seen some fabulous reports, and I think that's where my bias comes from, maybe.
Right.
But again, like another thing that I don't like that a lot of people probably all around the world are doing is like misusing Ozempic in terms of calling themselves aesthetic doctors who probably don't really have the understanding or probably the like the in-depth training of how someone should be titrated or how someone should be given a drug, and it goes wrong with the patient and it like causes a backlash. Like, what is your opinion on that? Like,
so I think if you're taking GLP-1s without proper guidance, I don't think it's going to work for you like it should. I'll put it that way. So speaking again from clinical experience, I've worked with GLP-1s now for over 8 years, and I think there's a way that you would need to eat on it. There's a way that you incorporate certain macronutrients. I've had patients who've used GLP-1s, maybe prescribed with good intention, but they come and they're like, it didn't work for me. And then we have to kind of unlearn or understand what they did and unlearn that.
right.
And try to explain to them. So I think it's really important whenever you start considering this in your journey, in your weight loss, metabolic journey, that you discuss it with someone you trust, a doctor you trust, a doctor who understands what they're doing, rather than just going to maybe someone who doesn't have that expertise.
Right.
Because it is novel right now here for India, but it's working otherwise everywhere
Fair
else.
enough. So, now that we've discussed the pros, the cons, the good, the bad, and the cautions, I think something that I want to do for my audience today is like literally break down the basics for them. I mean, if someone has been obese, I mean, ideally, just in general, what are the basic lab tests that they would need to get done to see if they have those metabolic markers for which they might need something like an Ozempic?
So, first and foremost, I usually, we start off with all the vital signs. Check your blood pressure, check your fasting blood sugar, check your weight. I don't like to just go by weight, I'll be honest with you. I like a body composition analysis, but let's start with the basics. The other lab parameters that we check for, I like to check for your HbA1c, your fasting insulin, your liver profile, even your kidney profile. I want to make sure that everything is okay there. And then along with that, I do check certain supplement levels or certain micronutrient levels that I want to make sure, because that gives me some idea about gut health as well. Of course, I screen you for mental health issues, and then family history. Family history is key and lifestyle is key. We have to look at all of that because that gives me a whole picture. Otherwise, I don't like to just look at labs. I like to look at my patient. I also go into sexual health as well. I want to know, how are you doing, with your partner or your desire, whatever it is. Because look, the hormones at play are also there.
Absolutely.
And I have a very transparent kind of picture in my clinic. I'm very open about it.
Honestly, you have no idea how much I resonate on this with you, because like whenever I see some patients as a health coach, like it's the same thing.
Yeah.
I first ask, in fact, this is one of my first questions.
Yeah.
How's your sexual desire or sexual feeling like, because I think most people completely ignore that, especially after a certain age. They feel it's okay. It's like, I'm not 20 anymore. I'm not 18 anymore.
Yeah.
And, it's okay if it's gone
Yeah.
or it doesn't matter.
Yeah.
And I feel like it is those behavioral changes in those people that make all the difference.
Yeah. Absolutely.
In your motivation of doing anything.
100%. I think it is a clinical sign or symptom. Like if you came in and said, I'm fatigued, that's the first thing I'm going to ask you. Yeah, of course, with age and with certain hormonal changes in females, we are going to see a decreased libido, right? We know that.
Right.
But in a male who's obese, and I'm looking at him and I'm like, listen, you're 35, you're 40, you should be getting a certain amount of morning erections. You should be getting a certain desire. But a lot of these men, they think it's normal, that they're not. And
I think with men, it's a big stigma to even talk about it because I feel like feeling sexual or horny is the biggest health flex a person could have, like on a daily basis.
I think the same thing with obesity. I think there's this huge stigma. Nobody wants to talk about it. We do these preventative health checks. And it's like that elephant in the room. I know it, you know it. Like we're looking at each other. Okay, so what next?
Yeah.
So there's a conversation that a doctor also needs to know how to have. With the patient.
I'm just out of experience. I feel like I don't blame doctors because I think more than intention, we need to look at the burden of doctors in India.
Yeah, true.
There are very few good doctors.
True.
And, in India, all of us want to go to the good doctor.
True, yes.
And, if I have 50 people sitting outside who want to talk to me for 5 minutes, I'll be like...
I understand. Yeah, absolutely. Overburdened. So there's a solution to that, I think. I don't know, Anant, I don't know. But what I like is the team-based approach. Yeah. And I really think... that is the key going forward. What I've seen is I was handling everything in my obesity clinic practice where nutrition, mental health, and I was like, I am not doing justice to my patient nor justice to my field. I need to delegate this.
Right.
So I have knowledge, but I don't have that expert knowledge in nutrition.
Right.
I have an interest. I've understood certain things, but I need to delegate this for the benefit of the patient. I need a mental health specialist who needs to work with this patient. I can help this patient only so much. Let me manage this patient medically.
Absolutely.
And a health coach is also really important. A subspecialist is so important. And I think the beauty would be if we all sat down
together
at a table. And we used to do this. And so in hospital medicine, there's something called tumor board where we discuss very complicated cases and cancer cases. And we bring all the specialists and we discuss the patient. And we, when we're stuck, we work together as a team. So it's not like it's impossible.
Right.
You need the right team to give you the best results.
And I think this is what exactly we're trying to bring in India general.
We should.
As an obesity clinic where patients have access to comprehensive health.
Correct.
Rather than going to 10 different doctors and searching for something
There's also that saying that too many cooks spoil the broth.
Yeah.
So I've experienced it myself and I've seen it myself where people, when they're doubting or maybe they're not satisfied, they'll go for more opinions. I agree with the second opinion. I even agree with the third opinion. When you get too many opinions, you're very confused.
Yeah.
Right? And you don't find any solution then.
And it also puts a patient's mindset off towards medical health.
Yeah,
they
absolutely.
feel like, I went to 10 doctors, it didn't work for me. This is not something I want to do. You just tell me what to eat. I will walk in the morning and it'll be fine.
Yeah, many times I've heard, just give me the holistic approach. Yeah. I am giving you the holistic approach. I feel like you and your patient, and I know this is not easy, but you need to find someone you can have a good, open relationship with. Yeah. And I've always said this, that you need to have a doctor I'm not saying your friend, I'm saying someone who you can talk to openly with and someone who presents to you the pros and cons of you being on it. Obviously, a good educated physician with the knowledge, that's what's needed. You just need to have a conversation with your patient.
I think something that we missed in our conversation was the nutrition part, where I think protein is one of the key elements here, is that because you're not feeling that hungry, you might eat less and you might have less protein. I think to avoid muscle loss, besides working out, I think protein is something that we should take, because I feel the mistake that most people make in terms of nutrition is that they have too many carbs and they don't have enough protein to fill the lesser appetite they have. and they end up losing more muscle mass.
Right.
But having said that, no matter how you lose weight, you will always lose muscle mass. Like this concept that Ozempic makes you lose muscle mass is ridiculous, because if you lose weight, you can't lose all fat mass. If you're working out, even if you're resistance training,
Right.
and you say drop 20 kgs in the
Right.
gym,
Right.
you will lose 4 to 5 kgs of muscle mass.
Right.
And with Ozempic, maybe it's a 10% extra, but
Right.
that's about it.
From my practice, I have seen anywhere between, like you said, 1 to 4 kgs of muscle mass loss. But that's why that follow-up is so important on it.
Yeah.
Like, so if I tell you to come back in 6 weeks and I need to do a body composition analysis on you,
People won't come.
people are like, why do I need to come? I'm like, this is why you need to come, because I need to understand. You need to understand
Yeah.
more than me.
Yeah.
I know what's happening, but you need to understand. So, and we'll show you, look, this is your muscle mass. This is your body fat. You're losing muscle mass. That means you're not getting enough protein. So the follow-up, the regular correspondence also, like just an update,
Yeah.
with like, hey, this is what's happening. If you don't tell me, I'm never going to know. And I won't be able to give you a solution.
Right.
I have a great case, which if we want, we can discuss it now or later. But something like this, which has led to a success story.
Right.
Where I have a patient, and she has been struggling with her weight for, I think, over a decade. Her daughter must be 10, over a decade. And she said, I've been to an endocrinologist. I've been to many nutritionists. She's in the healthcare field herself. And she came to me, she's like, I've just heard about you as an obesity medicine. You're my last resort. Like, I don't know where to go from here. Yeah. And I've just heard about you. And she shows up and all her metabolic panel, the whole metabolic panel is off. She's on 2 thyroid medications. Her TSH is above 20. Yeah. Her insulin levels are very high. Her liver profile. And she's like, I am so tired. Like, she granted high stress level job, everything. So tired. She's like, I don't know what to do. I'm not losing. I know I need to lose weight. I have PCOS. I can't tolerate any of those medications. I've been on birth control. I've been on metformin. And, it was a lot of understanding her backstory, what she's been through, for us to cater something specifically for her. But what we saw, it took time. And she was persistent and she was patient, which was beautiful, because a lot of times what happens, people get demotivated. Ek mahina ho gaya, I haven't lost anything. What happened? And she, luckily I think she understood her body more than anything. And we also did a lot of counseling. It's going to take time. Started her on GLP-1, gave her full guidance on nutrition, how to eat on it. She followed up with me very regularly that, doc, I'm not able to tolerate this dose, or I'm having a lot of gut issues. We fixed it. I heard her, we fixed it. And I think I saw her after 5 months. I had her repeat her blood test. TSH is the poor thing was struggling for so long. And I was really happy to see the numbers, because I am a very data-oriented person. But then I saw her physically, and I saw, not only did she look smaller, but she was happier.
Yeah.
She was working out. She was feeling energized. Like, these are the things, like, we're not chasing an image. And that's what I loved about her. She wasn't chasing. She's like, I know my body type. I get it. But I just want to feel better. I have a young daughter. I have a family. And it was such a gratifying experience and humbling experience for me. Medicine is very humbling, right? You could think something and then something else happens.
That's a wonderful story, because that just proves that GLP works on so many levels. It's not just about, like you said, image or like the way you look.
Yeah.
Because the moment your metabolic markers change,
right,
your hormones change.
Yeah.
And like, I can't even begin explaining how hormones influence behavior.
Oh, I think every woman knows how hormones influence behavior, and men as well.
Yeah, it's like, hormones like are the very basis of how you behave, like what makes your being.
Human nature, I think. Yeah,
absolutely. And like, but just moving on from Ozempic to Mounjaro, like, do you feel, even though we touched on it a little bit, do you feel Mounjaro is a better drug than Ozempic?
So I do think it is a better drug for glycemic control and for weight loss. Yes, I do. Because remember, it acts on 2 receptors. And by the way, GIP receptor agonists also help with lipolysis. I forgot to mention this earlier, but
Right.
it helps with fat burning capability as well. So I do think it's a superior drug to semaglutide. Now, how someone responds, everybody is different, right? If I give you a medication, you may respond amazingly to semaglutide, but maybe not as well to terzepatide. And that's for us to see as we're taking it. But I do feel terzepatide's a better
Right. Because, like, I want to move on to the future of these drugs because semaglutide, GLP-1s are just the starting point. And, we got Monjaro, which is
Yeah.
tirzepatide. And
Yeah.
now, something that's going to be approved in a year or so is retatrutide.
Right.
So, it's a triple agonist.
Yeah.
Where it's, I think, glucagon agonist.
Yes, that's the third one.
There's the
Glucagon.
third one.
Yeah.
And that's going to burn your fat even further.
Yeah. So
What's the future after that?
So there's another GLP-1 that's in the works, or for glipron, which is an oral non-peptide GLP-1. So what we'll see is better absorption with that medication and hopefully more weight loss as well.
So it's a non-peptide, meaning it's like not re-engineered E. coli bacteria. Like it's...
Right. So it's a non-peptide and it won't also get degraded by the stomach acid as well.
Okay. That's interesting.
Yeah.
I think the future of GLP-1s is insane. I'm sorry, I'm terming it as GLP-1. Like fat loss medications because I read a paper that DNP is coming back. Like it was banned in the 1930s and it's coming back. There's so many new things coming out. I think, we always spoke about how our future is doomed because of obesity. But I think pharma is doing really well in the sense for obesity because I think we might just solve obesity by 2035, 40. I don't know. I might be wrong.
No, I think it's a very valid point that you have, but not alone just with the GLP-1. I think, right?
No,
just
fair enough.
lifestyle.
I think GLP-1s brings about like a behavioral change in people because once it starts getting normalized, everything initially is something that is always, I remember when computers were coming to India.
Yeah.
People were so against computers. They thought, it'll take away jobs. AI is coming to India.
Right now we're also, thinking doomsday
Thinking,
will
oh
come.
my God,
with
doomsday
AI.
will come. Like, I think GLPs are in the same line. Like, GLPs are coming and people think, oh my God, the world is going through so many side effects and blah, 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 blah. But like, what will happen?
Exactly.
Because, in the last section, Dr. Roohi, I really want to talk about the stigma of obesity medicine.
Yeah.
When someone has blood pressure,
Yeah.
Everyone in the family will make them remember to take your blood pressure medications, every day. Remember to take your thyroid medications. Remember to take your PCOS medications. But when it comes to obesity, people think they're cheating. Why do you think that stigma exists?
That they think that the GLP-1 medication is a shortcut.
Yes.
Right. I think that it's misunderstood. I think that is the problem. That there's a stigma around obesity, that we blame the individual, that he doesn't eat right, he doesn't exercise enough, it's his fault he's like this or she's like this. And I think we need to break that stigma first. Same thing I could say with someone who has diabetes or hypertension then, right? Oh, doesn't take care of himself, that's why he has high blood pressure. We're forgetting that maybe he's genetically predisposed to it. Maybe we're forgetting that he has a high stress level job. Maybe his diet is off, he's taking in too much sodium. Maybe he has a renal problem, right? Just like that, we have to look at obesity with that fine lens. That, look, it's not only his or her fault. Could there be a hormonal issue, right? 100%. Could there be a nutritional issue? They're not absorbing enough nutrients, and there's a gut microbiome issue where fat is being absorbed more, 100%. Mental health, I think that's the most, it's on the top of my list. Stress eating, nighttime eating, binge eating. This is all due to mental health. And lack of movement, 100%. That's there as well. We have become sedentary. I think the human race has become sedentary. So you have to start looking at it differently. And I think it starts with the clinicians and the doctors and the nutritionists, and then that's what's going to make that change come about. That we have to look at this as a disease, first and foremost. And just like we would treat diabetes with the medication or high blood pressure with the medication, we should treat obesity, especially for those people who have chronically been dealing with it their whole life. Why wouldn't we? If I can increase 10 years on this individual with the help of a tool,
Absolutely.
right? Why wouldn't I give them 10 more years? And I think even with bariatric, I bring this up again as well. Bariatric surgery is also an option for certain people. But there's a way to explain how to eat after that as well, or how to eat during bariatric. So it's awareness, and the stigma is not only with the medications, it's with obesity. So first, let's change the stigma with obesity. Then only will we understand how that medication is helpful.
Because I really resonate with you at this point, because like you've put it beautifully and you've put it like in a very professional manner. And I'm going to be a little crass about it. It's like when people tell me that they want to sort of, naturally lose everything, I'll be like, okay, like, let's do this. Like, let's wake up at 5:30 a.m. in the morning, go for sunlight, go for a run, do resistance training for 2 hours, eat this much amount of protein, be like, have no stress at all. Like, have your mid morning snack, have a good lunch, protein heavy, and then just do everything right and not have any mental health trauma, not have any hormonal issue. All that will go on its own. Just do this for another 2-3 years and you'll be there. They don't want to do any of that, like most people or most patients. Like, they don't want to do any of that. Just tell me what to eat.
Just tell me what to eat. Yeah, 100%. Yeah. But that's the thing, like, they need to realize that no matter what weight loss method they adopt, they'll have to make changes to their lifestyle. Yeah. You have to. I come from a family that is obese. I see it in my household. I myself have struggled with it. And I think that this is something that we need to accept and we need to change going forth. And
we absolutely need to normalize this. I think
we need to.
Just like any other medication.
Just like any other disease. We need to normalize this. We need to stop blaming the individual and we need to start treating them, like, honestly. And I hope people will start accepting treatment options. And it's not just limited to medication. It is limited to, like I said, all the other issues that we talked about, the hormones, therapy, everything.
I think, like, just as an ending note, I would also want to tell, like, just besides the general public also, I would also want to inform some of the doctors who are against it. Because, like, we find that there is a large medical community also which is against it. Like, I don't know why, but they are. Because I've heard back from so many patients saying that their doctors don't want to give this, or their doctors are against this. I would want to normalize this for everyone. Like, if you're giving your patients medicines for blood pressure, thyroid, and all the other metabolic factors, it's absolutely okay to give medications for obesity or extreme type 2 diabetes.
I'm so glad you brought this up, because I can't forget, I had a patient come to me. I put her on a GLP-1. And her family doctor said, "You're not a diabetic. You're not obese. No, this medication is not for you." And, honestly, I understand that certain doctors maybe are not aware, especially certain older doctors, maybe not aware of the newer medications. When I'm also 70 plus, maybe, I need to kind of, obviously update myself, which we do. We have to update ourselves every year as doctors. But I think it has to change in the medical community as well. Be aware of what's available. These medications can change your patients' lives, especially high-risk patients. I bring this up, but I can't forget that patient, and I showed her the evidence. I showed her the paper. But obviously she had her reservations, and she chose not to, and that's fine as well. I'm never going to force you to do something you're not comfortable with.
Fair enough.
But yeah, you're right. The medical community definitely needs to understand what's available now.
Dr. Roohi, thank you so much. I think we had a very comprehensive conversation around Ozempic, Mounjaro. I'm literally going to title this, like, everything you need to know about Ozempic and Mounjaro. But thank you so much for having this conversation. I think we spoke very comprehensively. You've been amazing and given us some case studies as well. Thank you. And, I'd like to have you for many more podcasts on obesity.
Sure. Thank you for having me. And I think it was I think we had a great talk.
Yeah, absolutely.
I think we had a great talk.
Thank you so much.
Thank you.